Hello everyone, welcome to KB Lim Skin Clinic. I'm Dr. Lim. This is a short video on atopic dermatitis. Atopic dermatitis or eczema is a chronic inflammatory skin condition that is characterized by intensely itchy, dry red patches of skin. The term atopic comes from the Greek word atopy, meaning out of place or strange. It describes a predisposition towards developing certain types of allergic hypersensitivity reactions. Atopic individuals have higher levels of IgE antibodies in their blood compared to normal individuals. Atopic dermatitis patients often have associated asthma and hay fever, also known as allergic rhinitis. These three conditions are termed atopic diseases, and together doctors refer to them as the Atopic Triad. Atopic patients, meaning all those with any of these three conditions, have higher levels of IgE antibodies in their blood compared to normal, as was mentioned earlier. Atopic diseases tend to develop in a pattern beginning with atopic dermatitis, then food allergy, rhinitis, and asthma. Doctors refer to this progression as the atopic march. Atopic dermatitis is the most common skin disease in children, affecting 15 to 20% of children, or 1 in 5, and 1 to 3% of adults. Although atopic dermatitis tends to improve with age, about 20 to 30% of patients continue to have problems in adult life. Doctors believe that 4 factors interplay to cause atopic dermatitis, namely 1. Genetic factors, 2. Epidermal barrier dysfunction, 3. Immune dysfunction, and 4. Environmental triggers. Let's have a look at these. 1. Genetic factors. A positive family history of atopic disease can be obtained in 70% of patients with atopic dermatitis. The odds of an offspring developing atopic dermatitis is 2 to 3 times higher if one parent is affected, and 3 to 5 times higher if both parents are affected. Further evidence of a genetic basis for atopic dermatitis comes from studies by researchers in the University of Dundee, who first found filaggrin gene mutations in Ichthyosis vulgaris. This is a skin condition that causes fish-like scaling, usually on the legs. Patients with atopic dermatitis sometimes also have Ichthyosis vulgaris. Later, about 3 years later, other researchers found the same filaggrin gene mutation in patients with atopic dermatitis and in patients with asthma. 2. Epidermal skin barrier defects of dysfunction. Atopic skin shows increased enzyme activity, protease including protease activity, which can actually lead to the degradation of cell adhesion molecules that bind epidermal cells together. This affects the integrity of the epidermis. In addition, atopic skin also has a higher pH, suggesting that the skin's protective acid mantle is also affected. To make matters worse, there is reduced production of filaggrin due to the gene mutation I mentioned earlier. Filaggrin is a structural protein. It is also important. It acts as a glue that binds epidermal cells together. Hence, reduced production leads to the loss of some of the integrity of the epidermis. In addition, filaggrin breakdown products contributes to the skin's natural moisturizing factors. So in a sense, atopic dermatitis skin lets moisture out when it should be keeping it in, and it lets allergens and microbes in when it should be keeping them out. 3. Immune dysfunction. An increase in numbers of T cells have been found not only in the affected skin, but also in the normal skin of atopic dermatitis patients. In particular, a subset of T cells known as Th2 cells are activated. Activated Th2 cells release inflammatory cytokines such as interleukins, IL for short. The ones that are highlighted in red are the ones that are targeted by modern biologic therapy, which we'll discuss later on. Just to briefly summarize what we have said so far, atopic dermatitis is a disease of skin barrier defect of dysfunction and Th2-driven inflammation in which genetics play a role. 4. Environmental triggers. An increased incidence of atopic dermatitis of 2 to 3-fold has been noted in industrialized nations, since the 1970s. Doctors and researchers attribute this to environmental triggers. Many environmental triggers have been implicated. This is just a list, some of the environmental triggers, which include hardness of water, contact irritants, dryness, including dry air, airborne allergens such as house dust mite, animal dander, pollen, and moles. House dust mite in particular can also produce protease, which we heard is an enzyme that can degrade cell adhesion molecules. In addition, house dust mites have antigens that can trigger an immune response. Atopic skin often harbors a bacteria known as Staphylococcus aureus. It can be found in up to 90% of atopic dermatitis skin. This bacteria produces ceramidase, which is an enzyme that can break down ceramide. Ceramide is a lipid that's important for skin barrier function as well. In addition, Staph aureus produces enterotoxins. These are super antigens, which means the antigens can hyperstimulate an immune response. In addition, some patients with atopic dermatitis have associated food allergy, such as to peanuts, cow's milk, and egg white. Food allergy does not cause the eczema, but it stimulates itching, and that makes eczema worse. So avoidance of food allergy is important. In addition, some patients eczema can be triggered by emotional stress. It can also be triggered by rough textured and woolen fabrics, which stimulate itching, and that causes eczema to develop in those areas. Sweating is also a triggering factor as well. Atopic dermatitis may occur in subacute, acute, or chronic forms. This patient has subacute eczema, which is red, dry, scaly skin on the shoulder and chest. You might be able to see the excoriations. It's an itchy condition, and these are scratch marks. This is a patient with acute eczema, which is characterized by weeping, crusting, oozing, and blistering. This patient has chronic eczema, which is characterized by lichenification. Lichenification is the term we use for the leathery thickening of the skin, as shown. Atopic dermatitis affects different areas of skin in different age groups. In infants and young children, it usually affects the face, neck, and the outer aspects of the limbs. The outer aspects of the limbs are termed extensor area. So this distribution of eczema is often termed the extensor pattern. In older children and in adults, it usually affects the fold areas in the neck, front of the elbows, and back of the knees. These are termed flexural areas. So this distribution is often referred to as the flexural pattern. The diagnosis of atopic dermatitis is based on clinical appearance and history. In selected cases where the diagnosis is uncertain, the doctor may order a total IgE antibody blood test or a skin biopsy. Allergy to contact allergens, products that come to contact with the skin, can be detected using a skin allergy test known as a patch test. Patients who are allergic to airborne allergens, food allergens, can also be tested for allergies using a skin test, which is called a skin prick test, or it can be tested on blood to detect allergen-specific IgE antibodies. Atopic dermatitis can be scored according to extent and severity. There are two grades shown here, but there are others. SCORAD, which stands for Scoring Atopic Dermatitis. EASY Score, that stands for Eczema Area and Severity Index. Psychological suffering can be quantified according to the Dermatology Life Quality Index, or the DLQI. Complications include bacterial infection. You've heard that Staph aureus is commonly present on the skin of atopic dermatitis patients, so it's not surprising when it actually causes an infection. Atopic patients are also more prone to viral infections, such as to the herpes simplex virus or the cold sore virus, also to wart virus, and to molluscum contagiosum or water warts. They are also more prone to fungal and yeast infection, and some patients may suffer ocular or eye complications. This patient has herpes simplex virus or cold sore infection. She has atopic dermatitis, and it has led to a condition known as eczema herpeticum. This condition looks rather like chickenpox. It's very severe and progresses rapidly, and immediate medical attention is required. Atopic dermatitis can be treated with topical agents such as topical corticosteroids, topical calcineurin inhibitors, such as pimecrolimus and tacrolimus, or you can treat it with oral medication. One of them is oral antihistamines. This is almost always prescribed because controlling itch is very important. Itch causes an itch scratch vicious cycle that makes eczema get worse. And in addition, itch very often precedes the rash, and doctors often refer to atopic dermatitis as the itch that rashes. Control of itch is therefore very important, and oral antihistamines can be taken safely long term. Immunosuppressive therapy are oral agents that work by suppressing the immune system. These include cyclosporine, azathioprine, methotrexate, and mycophenolate mofetil. These are only used when eczema cannot be controlled on topical treatments and light treatments. They are effective, but they have side effects, and close monitoring is necessary. As mentioned earlier, atopic patients are sometimes also treated with light treatment. Light treatment is safer than the immunosuppressive drugs I mentioned earlier, but not all patients find this treatment useful, or some of them find it's a bit uncomfortable. Both ultraviolet A, UVA, as well as ultraviolet B, UVB light may be used. Ultraviolet A is usually combined with the prior taking of a light sensitizing medicine called Sorolin. So the treatment is called Sorolin UVA, or abbreviated to PUVA. Ultraviolet light B can also be used, and narrowband UVB and UVB is often the type of UVB that patients use nowadays. Finally, we have a group of immunomodulators, also known as biologics. This is the latest advance in the treatment of eczema. Biologics are basically proteins or sugars that are produced by living organisms. Dupilumab injection is the first biologic approved. It blocks the inflammatory cytokines I mentioned earlier, in particular interleukin-4 and interleukin-13. It is very effective, and its wider use is basically limited because of the high cost. Crisaborolcrin is actually a small molecule. It works by inhibiting a phosphodiesterase 4 enzyme, and thereby reduces inflammation. In addition to treatments, always avoid the triggers, whatever they might be, and very importantly, always moisturize the skin. Moisturize, 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 especially after a bath and shower. Atopic dermatitis is chronic or relapsing, and the patients often suffer flares, but between the flares, the eczema appears to be quite inactive. But even during inactive periods, research have shown that even in normal skin of atopic dermatitis patients, there are increased number of T cells, suggesting that there is subclinical inflammation. So doctors now advocate proactive treatment, which is treatment in between the flares, applying a topical product intermittently every 2 weeks or so to previously affected skin. This helps to reduce the frequency of flares as well as reduce the intensity of flares. So this is recommended as a maintenance treatment, if you like. So I hope you found this useful and informative. Please visit us at www.kblimskinclinic.com for more videos and educational material. And I would like to thank you for watching and look forward to seeing you again. Goodbye.